So thanks everyone for joining this breakout. I think a lot of you actually that are in this room are somewhat familiar with our programming, but our goal is to share with you and present what we are looking at with our POEM program. So this program stands for, or POEM stands for, the Pharmacist Optimizing Oncology Care Excellence in Michigan. And I want to start off by giving you a little bit of background to the program and share with you some opportunities and next steps as we move forward. So again, I shared with you what this acronym stood for. This program, POEM, is a partnership that exists between MOQC and the Michigan Institute for Care Management and Transformation, or MICMT. And it is supported by Blue Cross Blue Shield of Michigan. Our goal of the program is really to embed pharmacists in oncology practices across the state. And to give you a bit of background for those of you who aren't familiar with where this came from, Blue Cross had supported a program called MPTCQ, lots of initials or acronyms with everything we're doing with our quality improvement programming, but it was a program that several years ago was launched by Haimi Cho, who is a primary care pharmacist, where she worked to place primary care pharmacists into POs, or physician organizations, across the state of Michigan to manage patients' blood pressure, diabetes, CHF, and asthma. And in this programming, found that patients were able to, when they were managed by these pharmacists, meet quality metrics of care more efficiently than without that model, and that practices and POs were actually able to meet national standards for the care of that patient population more often than without a pharmacist in those services. Ultimately, the primary care pharmacist being embedded into these practices justified itself cost-wise based on the costs that were saved in providing exemplary care to this patient population, and the pharmacists remain in those sites and practices currently. So despite the model itself being completed, the justification of their care and service remained. Blue Cross felt that this program was so effective, and we're so happy with how the interdisciplinary care was managed and what they saw, that their goal was to expand into specialty areas. And they decided to approach MOQC to see if expansion into oncology could be the first place. And so that's where we are today. And it gives you a little bit of background of why would Blue Cross want to support this? And it's really been because of success and experience they've had in the past. It's also what we've known in some of the care that we've provided in interdisciplinary settings. And as we talk about the goal or focus of these pharmacists that we're embedding into clinics, you'll also see that some of the reasoning is based on changes in how patients with cancer are treated and managed. So to give you an introduction to our POEM team, I'm the director of this project on the MOQC side, and we partner very closely with MICMT. So Julie, who is on the phone or on the Zoom, is our project lead manager for implementing this program. And Ashley Schwartz just started with us as a project manager and is working with us. We also have an intern, Ariel Davidson, who is working with us on our project. And so this core team comes together regularly as we're rolling it out, and it is available to you for any support, questions, or anything as we move forward. So a little bit of background regarding oncology pharmacist scope in general. Oncology pharmacists have quite a broad scope that extends beyond simply the provision of medications or chemotherapy to patients with cancer. And within this scope, which I think is well recognized, I just want to highlight the fact that pharmacists who care for patients with cancer, that they have long been involved with generating, interpreting, and disseminating cancer-related information. So a lot of our projects or scope of care that we're looking at is going to be related to patient education in the practices and the management of side effects that we see with this patient population. We're looking at showing several different outcomes related to the pharmacist management with this program. So our goal is to see if we can decrease unintended healthcare utilization by decreasing ER visits and inpatient admissions. We're looking at several cost savings initiatives, particularly as it relates to overutilization of medications that may not be warranted in particular settings. And then we are also looking at or focusing on medication utilization evaluations and patient-related outcomes. So much of what we're tracking is related to the patient experience, patient-reported outcomes as far as symptom burden and how they're able to manage their own symptoms and their confidence in doing so. So the oncology pharmacist, as far as the value, incorporating this program as it relates to specialty oncology versus what had previously been done with primary care is a little bit tricky because of the fact that pharmacists who have specialized in oncology and have worked in this setting have been involved in a wide array of patient care exposure. And so unlike the primary care model that was rolled out and was very well established as far as the patient to pharmacist ratio, the exact patient population who would be followed by the pharmacist, oncology has been a bit more broad as far as what the pharmacist's engagement with the practice has been. So not only are we looking at focusing on a particular group of oncology patients and assessing the patient population who would be best served by the clinical pharmacist role. We're hoping to narrow the scope within this project, at least, so that we can have a better tool used to justify services as we move forward. I'll leave the slide here as some background, but again, I think to highlight the value and where we've seen documentation of pharmacists improving value has really been in managing and supporting symptoms, in helping with reviewing medication profiles and ensuring that they are without risk as far as drug interactions and other complications, and in general medication management or therapy management programming. So programs that have specifically shown the things that were in the prior slide fall into a couple main categories. One of the biggest areas that oncology pharmacists have shown greatest value in as of recently has been related to the management of oral chemotherapy. And as you know, more and more treatments of patients with cancer are targeted therapies that are given orally, sometimes for quite a long time. This has become very difficult for clinics to manage because the care is no longer contained within the clinic setting, but prescriptions might be provided by an outside source. Patients may be receiving information or education from an outside source. How they're managing their symptoms on a day-to-day basis is really done on their own, not with the support of others on the team unless they bring it to their attention. And so a structured way of managing this patient population as far as education and follow-up has shown in the literature to provide quite a bit of value to patient care. And in these settings, we're really looking at things like how long can we keep the patient on their therapy longer by helping with the management of their side effects? Can we help them with medication adherence, which has long been a support that pharmacists have provided? And how can that impact the care and offload some of the responsibility of other members of the care team? In addition to managing oral chemotherapy patients, we are also looking at how we can manage another fairly new drug class, which is that of immuno-oncology management. Very high symptom burden for patients with tight control and medication needed to help manage their symptoms and keep them on therapy longer. We have a couple publications that support the pharmacist role in this management and that show that by pharmacists being involved in the process and hosting a program to manage this patient population, that toxicities for patients can be identified earlier and that it can lead to prevention of downstream complications related to those toxicities. Finally, there is a plethora of ways for pharmacists to be involved besides these two distinct patient populations in really looking at overall symptom management and care management within a clinic setting. As you heard Jennifer mention in where we're moving as a collaborative, we are taking quite a focus on how we can interact with primary care and patients who have comorbid conditions. The complexity of medication regimens in this patient population is can make it quite difficult for the patient to receive ideal care, and pharmacists have been heavily involved in this area, and this is another focus of our programming. So our clinical focus of POEM is related to oral anti-cancer agents, immunotherapy, symptom management, the use of supportive care agents, and assessing pathway compliance. And how we determine with each site that we roll out our POEM programming in, of which area is to be the clinical focus of the pharmacists themselves, is really related to the site's specific needs, the patient population at that site, and really other established services that are already in place. So what does the engagement look like? So far, I feel like I've been somewhat vague in what the program itself provides and what this means as far as a practice who enrolls. So there's engagement on two ends. One is the pharmacist and practice. So the practice who's engaged will have a pharmacist at their site and hired by them. And then us as the coordinating center, so myself with Julie and Ashley, will have other responsibilities as we roll out this programming. So on the pharmacist or practice end, we're looking at participation, and that there is a participation of that practice with MOQC as a base. There's a separate agreement for participation with POEM that really is related to the data that we'll be collecting and showing what the outcomes are of the programming. The goal is that on the practice end, there's a commitment to embedding a pharmacist into direct ambulatory patient care. So the practice has to be committed to this model to take part. We would meet with the practice and the pharmacist once hired to agree upon a scope of work for the clinical pharmacist. That scope of work may include that a collaborative practice agreement is signed for the pharmacist to function under. And we also, as a part of this program, we support and help get the practice and pharmacist set up to make sure that they're billing for the clinical service they're providing. And so that's been a big part of support that we've been providing even as we've started with this pilot phase of the programming. Finally, we'll be collecting and sharing data. On our end, the POEM Coordinating Center will support the practice site in recruitment efforts. So if you don't have an internal candidate that you're looking at for this program, we'll help support you with recruiting. We provide resources and support to the pharmacist for the clinical service that they'll be rolling out. We have a team that will collect and analyze the program data and provide practice level reports related to performance and outcomes of the clinical service that's been implemented. We have regular scheduled mentoring, training, and follow-up with our POEM pharmacists. So we've had a pilot that we've been running for the last few months with 3 sites. We meet weekly with the sites, and I've loved so much these sites and the pharmacists who are there and the work they've done and all the information sharing that's been occurring. So that will continue throughout involvement with the POEM programming. We also, through Blue Cross's generosity with this program, support the funding of the pharmacist. So we will reimburse the practices 100% of the pharmacist's salary and benefits for year 1, so 12 months after they've been hired, 60% for year 2, and 20% for year 3. The expectation is on us as the coordinating center and the team that we will be able to show outcomes that make it worthwhile for the practices to say, of course, we would financially support this pharmacist moving forward. And that is what was shown with the primary care model. So we anticipate to have similar successes with this program. In addition to the pharmacist funding, so the funding of the actual position, Blue Cross has also provided a value-based reimbursement for participation. And so once a practice has engaged or decided to engage in the programming, whether the clinical service has been started or not, once they've signed the participation agreement with us, they are eligible to begin receiving value-based reimbursement, which is currently at 10% on all RVUs. So at this point in time, as we're piloting the program and we don't yet have our metrics to show what our outcomes are, this ability to receive the VBR will be on participation only. So the timeline, to give you a sense of where we're at, where we're going, when we can engage more practices, we launched the program in fall of 2020. We have 3 practices currently engaged in this coming year, or this current year, I guess, 2021. We're in it now. We plan to onboard 6 new sites. Our goal would be to have those sites onboarded by fall of 2021. So really we could begin at any point in time. 2022 and beyond, we hope to analyze data within this next year of where our pilot sites are and our next sites, and expand based on the learnings that we've seen within these first couple years. The program structure and involvement, our plan is that the pharmacist who's integrated into these practices will have 4 days of clinical effort, primarily being integrated into the clinical practice, seeing patients, providing direct patient care, and a 1-day allotment of administrative time. That might be divided by 2 days, so 4 hours one day, 4 hours the next day. Part of the time is when we have our scheduled meetings. We have weekly pharmacist meetings that are scheduled from 10 to noon every Thursday, and we've been working out aspects related to logistics, best practice sharing, going through collaborative practice agreement details and what that ends up looking at, like at each site. Other collaboration efforts, we have a shared drive where we share resources, next steps, movement moving forward. I mentioned to you our wonderful intern, Ari Davidson, who is also available for helping with background lit searches or other things that you might need done related to your QI projects. We talk about our updates with our database and entering in the data we need for looking at outcomes. We've had some educational programming to date to let you know that this remains a priority for our group, and also that ultimately our goal may be that we are able to do a better job of training up pharmacists who may not have as much oncology training in the background. And so far we've had a presentation related to oral chemotherapy programming and potential outcomes by Diana Kostoff at Henry Ford. I had this on here before I knew this presentation would be canceled, but we were about to have a patient-reported outcome presentation yesterday. That's being rescheduled due to a family situation. We also had all of our pharmacists complete the HOPA ASCO Quality Training Program webinar or workshop. That was a 1-day workshop related to QI in oncology practices. So I want to introduce you to our POEM pharmacists, and then I actually would like to not talk as much and leave it open to questions and have each of the POEM pharmacists go over a little bit of what their experience has been. Our goal of this presentation is for you to feel comfortable and knowledgeable about what our program intent is, what we're planning as we move forward, and to get any logistical questions answered about what we're doing. And so I'm going to introduce each of you briefly about what your roles are, and I'm going to finish off the presentation, and then I'm going to leave it open for you to each describe a little bit about what your experience has been, and then open it up to questions. So Emily is at St. Joseph Mercy, IHA HEMONC in Ann Arbor. Her clinical focus there is related to oral anti-cancer agent therapy. She has been able to have several things in place already, partly because of the success of actually that primary care program within the IHA practices. So a lot of what Emily has done and come in with was well recognized and appreciated already by this group. And so she has billing in place and has been able to see patients and educate and follow up on symptom management already that for those patients related to oral therapy. She has a collaborative practice agreement that has been written and is currently undergoing review, but includes symptom management for multiple symptoms that patients may experience, in addition to, based on Emily's expertise and background, some primary care management, so hyperglycemia and hypertension management for patients and statin adjustments. Her goal and what we anticipate as far as patients that she'll be seeing is that there are approximately just under 300 new starts of oral chemotherapy per year. She has planned 3 touches per patient as a standard, potentially more for patients who have high symptom burdens. So in total, that would be approximately 850 billable visits per year. In addition to this standard program that she has in place, Emily is receiving as needed referrals from the physicians that work in her practice currently. So when things come up with patients that aren't currently in this patient model of OAA therapy, they'll refer them to Emily for additional follow-up. So things she might do would be like comprehensive medication reviews or review for a new side effect that a patient's experiencing to see what type of medication might be contributing to it. One review point that all of us have discussed, which is quite time intensive, but I think also is valuable to the patients, is related to reviewing some of their complementary medications and how that can interact with their therapy or their disease. Our next pharmacist and site that we enrolled was with Cancer and Hematology Centers of Western Michigan in Grand Rapids, and Kristen is our pharmacist at that site. Her clinical focus is going to be immuno-oncology management. Her site already in this practice has an embedded specialty pharmacy where that pharmacist group already provides quite a bit of support to oral chemotherapy. And so that was something that was already well covered, and how she can incorporate perhaps improvement or review of that structure might happen, but they already have had a very successful program in place. And so she's looking at immuno-oncology management. She's already involved key stakeholders who have been really engaged and have signed off on the proposal. Billing opportunities are being finalized within her group and looking at the care that she provides. In addition to the care she's providing, these billing opportunities are being expanded to work that's already being done at her site. And so some of that opportunity might be able to be more so appreciated for care management support that's already occurring within the specialty care model. Her collaborative practice agreement is being drafted currently. I almost don't want to say this out loud because it seems so intense and crazy to me, but the number of patients, Kristen knows every time I talk to her, I'm like, are you sure that's how many patients you have? But their practice across multiple sites has in the 300s probably as average of immuno-oncology patients per year. And if you look at the amount of follow-up that she would have planned within this program, it brings her to almost 4,000 billable visits per year. So how we tailor that and it's more manageable for Kristen, or it looks at an expansion of her programming depending on the success, I think is currently under discussion. Our last pilot site that I want to share progress with you on is in Lansing with Mark. He will be focusing on oral anti-cancer agent therapy. He started later than our other pharmacists, so the progress may not be as far along. And also there are some logistics related to his site that are currently happening. So those two sites are currently merging, and so he's working through that process as he assesses need and his patient population. And he's currently working on billing opportunities and the collaborative practice agreement. He has another unique opportunity in that McLaren being part of the Karmanos, or Karmanos being part of the McLaren network, can utilize the Carmano specialty pharmacy. And so how that's best utilized as it and partners with that specialty pharmacy related to the oral anti-cancer therapy is something that we're discussing right now, and how to integrate those services. So next steps, we'd love for you to contact us if you're interested in taking part. The value-based reimbursement opportunity occurs on a quarterly basis. And so that can be initiated after contract signature. And so there is opportunity for that to be added multiple times. Logistically, again, the salary reimbursement occurs after the hire, and we have contracting information available. We provide reimbursement on an annual basis, so you don't need to wait for that like every 6 months or whatever else. We also, in our learnings from these sites, but even more so in sites that we've been looking at taking part with us and sharing with us, the question of care management billing opportunities from practices, both for pharmacists providing different care, but also for nursing providing care, has come up quite a bit. And there are opportunities that exist that may not be fully appreciated in practices across the state. And so MICMT will be hosting a webinar for us for oncology practices where they'll share logistics and details related to billing and how best to go about billing care management codes. We have from our team, actually, Ashley and Emily both will be present on those webinars to present the information related to it. And so now I wanted to open it up to discussion and questions. And I was also hoping if Emily, Kristen, and Mark, you could just maybe at the minimum kind of show your face, say hi to everyone in the group. And if anything, maybe a sentence or two about how you feel the program has been going. And then we can see if anyone who's present has questions about us related to the next steps.
Do you want me to start?
Sounds great. Thank you.
Okay. Hi, everyone. I'm Kristen. Thanks, Emily, for the great introduction and overview of what I'm currently working on. And thanks to everyone who joined our breakout session. It's really exciting to see other interest besides our small group that that's been growing slowly. So I think things have been going very well at my practice. We actually already have quite a number of pharmacists integrated into more of dispensing roles. So it's been a unique opportunity for us to see how we can utilize a pharmacist in a different way. So that's been fun. And then with my work to better manage our immuno-oncology patients, some of the work I've done has exposed other areas that I could help, such as our normal education process, which has been very well defined, and I needed to do some work to figure out how I could integrate myself into that. And we've already had multiple discussions about how our pharmacists can better support that education process. So I do think it's going very well, and I'm excited to see what great outcomes we can have for our patients who are on the immunotherapies.
Thanks, Kristen. Emily, did you want to go next?
Sure, yeah, thanks. I echo what Kristen said. It's wonderful to see this much interest in the POEM initiative. It's been really great so far. Being able to work with people at other practices across the state, I think that's a unique aspect of this program that makes it really fulfilling and exciting, that we feel like we can share ideas and also help each other through challenges. So in addition to what Emily had mentioned that I've already been doing at my practice, in addition to the educations for patients started on new oral chemotherapies, I've also been able to get involved in our site's use of a new specialty pharmacy through Trinity Health, and help kind of bridge over to that in terms of just getting patients access to their oral chemotherapy medications, which I'm sure all of you know can be somewhat difficult at times. And also working to better integrate our using our EHR to better help our patients report their own side effects and toxicities when they're on chemotherapy or immunotherapy, whether it's oral or not. And so part of that has been trying to work with IT to better understand how we can get patient-reported outcomes to be reported at every patient's visit. So those are a couple other things just to add to what my focus has been this first 3 months.
Thanks, Emily. And the aspect of adding patient-reported outcomes, although not really spelled out in the slides that I presented, has kind of been integrated into each of the projects that we're looking at and the areas of focus. So I appreciate you mentioning that, because I didn't before, but it's a really important component as we're looking at just the outcome of our programming in general. So thank you. Mark, I can see your face now. Do you want to go next or comment on anything that?
Yeah, sure. You all have done an amazing job and pretty much covered everything that I would have said, but I'll just kind of add, you know, for me and for our site, it's been very positive responses, especially from the patients. As Emily mentioned earlier, we've got 2 sites that are merging, and so there's a lot of stuff going on that way. But I've been following the patients and kind of calling them myself. And, you know, I recognized one in the lobby the other day, and he wanted to sit down and talk for a little while. And I've been making sure they get their medicines on time. So I've just gotten a lot of really good compliments from the patients, made some good interventions on a lot of people using herbals and that kind of thing. So I had a guy the other day that we took him off a bunch of his herbals. Well, he started his Imbruvica, and he couldn't say enough good things about the program. You know, my site's a little different. It's small too. We have one full-time oncologist and 2 kind of like 3/4 time oncologists, and trying to hire another 4th one, a full-time one, but still a decent amount of volume considering the size of the practice. So we're just trying to keep that going and work on the engagement piece. And I think we'll have some good outcomes.
Thank you, Mark. So for those of you attending that are interested in this programming or want to hear more or have questions of things that we haven't covered, I'm going to pause for a moment to let you to let me know what questions you have, thoughts, experiences, if you've been taking part with these pharmacists, or things that you think we should be considering in our next phases.
Hey, this is Joan Herbert from Mid-Michigan Health, and I know we're kind of already going down this path. We've had the collaborative agreements all agreed to by our 7 oncologists, so I'm pretty excited about that. I do have one question about patient-reported outcomes. Are any of you utilizing your EMR patient portal to collect that information?
You want to start, Emily?
I can talk a little bit about what we've done so far. We've been using, at our site, we use Epic, and there's a built-in oral chemotherapy survey that we've been able to offer at each visit for patients. And it's been offered on a paper version, but we're now trying to do more of it electronically. Also hoping that there might be room to then adapt that built-in survey to capture a little bit more of what is consistent with the patient-reported outcome survey that MOQC has developed, and focus more on overall well-being questions as well as more adherence questions. But we have been able to do that by whoever does the visit where we're teaching the patient about their new regimen. We send that questionnaire to the patient, and then it's returned to me in my in-basket on the EHR. And then that is something that I can respond to if that's a patient that I'm following. I get a notification if they have a high symptom burden, and then I can follow up with them automatically.
Great, thank you, Emily. So I see a couple of questions in the chat after it was noted that my slides were advancing. So one, it looks like as far as next steps what are the next steps? It's working. So I think next steps really are reaching out to us after this meeting. Julie and Ashley and I can set up a call with you and go through more of the logistics. And so I just want to comment that we're available at any point in time. If you can't access us or can't find our emails, I'll share it in the chat now, but you're also welcome to just email the general MOQC email, and we can follow up with you there. So anytime, reaching out anytime is really, we can help get you set up, enrolled, answer questions, share the contracting with you to see if you have questions about it, etc. There was another question related to QI programs that people could work on to improve care in this group of patients who are not one of the pilot sites. And in relationship to that, and Kate, I think that you probably have logged off already, it looks like, based on timing, but I'll share with the rest of the group and then I can send a message out to Kate. We're happy to share information that we've done QI wise. We're so early in POEM right now that it's so minimal of what we could share, except what we've done as far as scoping out projects and our planning. And so there's not a lot we can share at this point related to QI projects within this group. There is a fair amount that I can share with you related to what we've done within MOQC and how I could help support you in oral chemotherapy, be it with a pharmacist in your practice or no pharmacist in your practice, and some of the launching points and ways to start that programming off. And so I'm happy to work with any of the sites, whether you're able to participate or not, in other QI initiatives related to medication management, symptom management, incorporation of patient-reported outcomes, management of oral chemotherapy patients. So I'll just put that out there that we're happy to talk at any point in time. A question about NPs, any issues there in pharmacists coming in and kind of roles? And my guess would be maybe distinction of who does what, and perhaps even maybe some concern about someone doing something that someone else was doing previously. Could you all comment on that? Because I think that would be the best coming from you, especially since you are really the first oncology pharmacist within each of these clinic areas. So or clinical oncology pharmacists embedded. So you might be able to comment on what that interaction has been.
So I'm happy to comment on this. Specifically related to our immuno-oncology patients and my desire to help educate those patients, our APPs are the providers who are giving that initial education visit. And so initially my hope was that I would get to participate in that visit, but after collaboration, we decided that a more effective method of education for these patients would be for me to provide a 24-hour post follow-up call. So after their visit with our APP and our care coordinator and our social worker, I'll actually call them the next day to provide more targeted medication-specific education. And so at least at our practice, for the purpose of education only, we just had to collaborate to figure out how we could share that role versus one person taking it over or duplicating work. So we are just making some slight modifications to that education that they will provide so that it's not too duplicative, but that it's duplicative enough to stick with our patients. I would say that's probably the most collaboration I've had to do with that specific group of providers so far.
Great, thanks, Kristen. Emily, can you comment on what your experience has been?
Yeah, I would just add, I guess for my role currently, doing a lot of the education visits. Usually I'm the one calling them for that 1 week check-in for toxicity. Some patients are then also scheduled for a video visit or a phone visit with an APP. It's kind of whoever's first available. And we've been able to kind of share that. I think I probably have done the majority of those 1 week follow-ups, but definitely have also had patients where they're coming in for a weekly visit with an APP, for example, because they have a higher risk for whatever reason with their disease state. And in that instance, it may not make sense for me to also be calling them if they're already coming in weekly, but I can work with our APPs to check in and make sure that I get specific information from their visit regarding adherence and other things that the APPs may not have already gone over in their visit. So we've been able to kind of share the burden that way. And I think it's not been too much of a challenge or felt like anybody's role was being compromised in any way.
That's great, Emily, thank you. I am, just to be mindful, I think of our time and just everyone's been on for a long time. I want to respond to Claire's question here related to pharmacist qualifications that are required to participate. They need to be a licensed pharmacist. In this first pilot phase of the 3 sites, our hope was that the pharmacists would have some either residency training or have had clinical experience within an oncology patient population. I would say that our qualifications are somewhat moving, and it's because of the fact that with this program, we're hoping to also provide additional clinical resource and support. And so as opposed to perhaps other ambulatory oncology clinical positions where the requirements might be quite stringent, we have been a bit more flexible, knowing what support that our team can provide and some of the structure and education and resource. So I hope that that helps to clarify it, but our hope would be that we can expand even greater and beyond the availability of board certified oncology pharmacists across the country, because I think then we won't be able to fill our need. Does anyone have any other questions while I pull up our slides for the end of the meeting? And hopefully I can do this correctly this time. We'll see. I just want to highlight that if you know anyone who you think would like to take part, please let us know. We would love to engage with them. And even if it's just being involved and hearing what we're doing, we're happy for that too. So our goal really is to just enhance the quality of care patients are receiving and hopefully to decrease some of the redundancy as far as resources available to people. So a couple housekeeping aspects related to MOQC in general. We have these upcoming regional meetings that will be hosted. These are all on our website as far as upcoming events, so you're welcome to reference that there. We have the following upcoming biannual meetings that are scheduled, and so we're hoping in June, we will be live and in Midland for our next biannual meeting. So hopefully, provided all is well, we'll be able to see everyone in person. We also, as you know, through MOQC have a separate, and are you guys seeing these slides? Okay, good. That we have a separate subset of where we work with gyn-onc practices. And so with these gyn-onc practices, we have 2 meetings scheduled that will be coming up. We have a lot of resources online, and so I just want to share that with the group that when you go to the MOQC website, we have information about our clinical initiatives where it might give you some background and some information about how to take part in them and enroll. There's also a resources tab that gives you a lot of information about our resources, some of them which aren't partnered with our initiatives, and so you may get more additional information than what you would guess if you go to the resources tab and see what other information we've been able to share. And then I want to comment on or highlight for you some resources that are new to us this year and that are really based on feedback that we've received from practices. So in our last 2 biannual meetings, we had Michael Smith, who's a palliative care pharmacist from Michigan Medicine, present to us. He did a phenomenal job and received a lot of wonderful feedback from providers across the state asking for more. And so based on that feedback, we worked with him in creating webinars, which are now up on our website. Thank you to Vanessa's amazing skill of technology and getting them edited and getting them up and ready to go for this biannual meeting. And so you can see these resources. They're just, I think they're great. They're great backgrounds. They're great information on things that are not the standard necessarily. And so when you see these presentations, it will give you a sense of what to do when you've kind of done what is standardly in place and aren't sure what your next step should be. And then I wanted to share with you that the billing webinars that I already mentioned once before, they're on our events page. These are the dates and times. They are the same webinar, but were offered during different times to hopefully capture different people's availability. You are welcome to share with anyone. So MICMT is hosting these. They're incredibly knowledgeable about these care management bill or these codes. Blue Cross Blue Shield will be present and helping with describing again some of the availability of these codes and when they can be used. They will not be commenting on other billing aspects. And so if you're attending, it's not a billing catch-all, it's really related to care management. And I would say the area that we've seen the greatest opportunity in practices, even through the years related to these codes, has been really practices who have been looking at help and how they can resource some additional oral chemotherapy education management within their sites for either nurses or pharmacists to provide. So closing comments, we have instructions for CE that I'm going to share with you in just a minute. We're going to be emailing the decks out to everyone who's registered, so you'll have all the information. We'll be recording this and we'll have the recordings available at a later date. Please reach out to us if you have any questions. Please email me, Julie, or Ashley if you have any interest in taking part in this program, questions about it afterwards. We're happy to talk with you about it. So we have physician credit available. Again, all of this information will be emailed out afterwards. And then for the pharmacists, we have these credits available where you'll scan the QR code, or there are also links that will be emailed after this meeting for you to receive continuing education. So you are all free to go. Is that right, Erin? Vanessa? They're all free, right? Okay, good. So I'll stay on until everyone's signed off in case anyone has other questions, but otherwise, thank you for joining us today.